of our year-long webinar series, which is part of Governor Mills Opioid Response Summit. We're pleased. This is the first time that we've been with you since November 8th, and I can acknowledge that we're pleased to be able to offer another 12 webinars next year and maybe 48 webinars. And the next one will be on January 6th. After the new year. We don't have the topic for that yet, but we'll send it to you just as soon as we are able. We're very excited today for our final program of the year to have with us to address the topic of the role of the emergency medical services in Maine's opioid response. Sam Hurley and some of his staff from the Office of Emergency Medical Services within the Department of Public Safety. Sam is the director. He began in October of 2019. He holds two master's degrees and is currently finishing up his doctoral work at Johns Hopkins Bloomberg School of Public Health in health security. Before his career in Maine, he worked as an EMS director in Washington, D.C. And prior to his work in the regulatory environment, he has an extensive clinical experience as a paramedic in both rural and urban settings in North Carolina and Georgia. He's a native of North Carolina, and you may pick that up from his accent, which is significantly different than mine. I'm going to have Sam introduce Darren and Megan, who are with him from the EMS office. In closing my introduction, let me just say how much I appreciate. I know that the work of our EMTs in responding to overdoses. When you consider that we'll have over 9,000 overdoses in Maine this year, the vast majority of whom survive, 93% of them, the work of our first responders to get to those sites and to attempt resuscitation is just extraordinary. Again, 9,000. Regarding fatal overdoses, by the way, I did want you to know that we put the October monthly report on the Data Hub, the mainedrugdata.org website this morning. So the experience in October was not remarkably different than September. The numbers are quite grim. On the other hand, for every one we lose, we do save a lot. And we've got a number of responses that we are doing, and Sam's going to describe some of the new ones to us. So with that, Director Hurley, I'm going to turn it over to you. I'll come back and help on maybe on the questions and answers. I would ask that if you have a question to put it in the Q&A part of the screen. You can chat amongst yourselves too. The chat is not disabled, but I'd rather have you put your questions in the question and answer slot. And we will get to every question. If not orally at the end, we will respond by, we'll answer the questions on our website, operated by AdCare. I appreciate AdCare and Lorena and all the people, Madison Barassa, who's our new project manager for opioid response. And she's also with us this morning. So with that, Sam, it's all yours.
Thank you so much, Director Smith. And thank you all for joining us. Again, my name is Sam Hurley. My pronouns are he, him, his, and I am so excited to join you all today and talk about some of the incredible work being done by the team at my office, the Maine Bureau of Emergency Medical Services, as well as by EMS clinicians, that's EMTs, AEMTs, or advanced EMTs, and paramedics throughout the state of Maine in responding to the ongoing opioid pandemic or crisis in the state of Maine. I'm lucky to be joined today by two members of my team. The first one is Darren Davis. He is our EMS Substance Use Disorder Data Coordinator. He has 37 years of experience with public safety data and within the public safety field. And so we are excited to have him as a member of the team We also are joined by Megan Salois, who is our new Substance Use Disorder Response Program Manager within Maine EMS. She started that role recently as of October 31st, and she has an extensive background working in mental health and behavioral health needs since 2010. In various community settings, residential settings, and institutional settings in both Maine and Massachusetts. She's a licensed social worker, as well as certified mental health rehabilitation technician for crisis services, and she's a certified clinical trauma substance use specialist. And so we are excited to have her on our team, and she too, like myself, is completing her doctoral training, but hers is in trauma and addiction psychology. So we have an incredible team here at Maine EMS, and we are excited to tell you a little bit more about what we are doing and the programming we have to respond to the ongoing opioid crisis within the state of Maine. So just to give you kind of high-level overview of what we're going to talk to you today about, when we looked at the list of participants, there were people with a variety of different backgrounds and experiences. So we want to spend just a moment to speak about an overview of the EMS system, how it works. And then we are going to talk about Maine EMS data, because our data is very important to the state and informs a lot of other entities throughout the state, which we'll briefly discuss. And then we're going to talk about the programming itself, which the programming is based on the data. So there is some logic to how we're going to go through this. So this picture or diagram is really just a very rudimentary outline of the EMS system. So we have activation of the 911 system and EMD. EMD is emergency medical dispatch. So when you call 911 anywhere in the state of Maine for a medical emergency, all calls go through emergency medical dispatching. So particularly relevant to opioids is the emergency medical dispatcher provides instructions for rescue breathing, as well as the administration of naloxone if it is available. So that component also falls under the Maine EMS oversight umbrella of those pre-arrival instructions by emergency medical dispatchers. They then dispatch EMS units and first responders. That's the helicopter and ambulance and fire truck at the bottom of the screen. There are some fire departments that do both first response and transport, but not every fire department has an EMS agency. So sometimes that's a misnomer that every fire department's an EMS agency. That's not necessarily the case. While 60% of our EMS agencies in the state of Maine are affiliated with fire, it still leaves 40% that are not. And then you have an ambulance response. And there's a helicopter here because if there's a scene response, say for a motor vehicle crash where they dispatch a helicopter, they may go to the scene. They then respond to that call, provide care, and potentially transport to the hospital. This is going to be where our primary interventions will be occurring, is this care and lack of transport to the hospital. So with EMS, we cannot kidnap people. It's ill-advised to kidnap people or take people against their will. And so what you're going to find in the data that we're going to talk about momentarily is that approximately 20 to 30% of patients who are reversed with naloxone in the state of Maine opt not to be transported to the hospital. There's a variety of factors that may come into play for that decision to not be transported to the hospital. That may be the cost. People know that there's a cost going to come that comes along with riding an ambulance. There's a cost that comes with being checked in an emergency room and seeing a physician in an emergency room. There's also significant stigma. We know that there's stigma within EMS, and we know there's stigma within the emergency room, and we know there's stigma within the entire healthcare system and healthcare infrastructure. And so that is something we are working on addressing. However, that may be another contributory factor as why people do not wish to be transported to the hospital following reversal using naloxone. So that's going to be our primary opportunity for intervention and many of the things that we're going to be talking about today. However, from one hospital there may be transfers to other hospitals. So relative to the state of Maine, you may be transported to a rural small hospital and a local community hospital that may not have capacity to handle a patient in light of someone who is experiencing substance use disorder or someone who has subsequently experienced an opioid overdose. If, for instance, they are intubated and need higher level of care, they may actually need to be transferred from one hospital to another. That may be done by a ground ambulance, hence you see the little ground ambulance there, or it may be done by a helicopter, which is why you see a helicopter on the larger hospital. So there is that subsequent movement of patients based on their needs. The last thing, and it has a little dotted line because it's not connected to the EMS system that we traditionally think of, is community paramedicine. So the traditional EMS system that most people envision is calling 911 and an EMS agency arriving. I would also somewhat lump in interfacility transport, because typically it's because of a patient needs to be moved to another facility, often urgently because they need stroke care, STEMI care, post-resuscitation care, etc., or surgical care. Community paramedicine is non-emergency. So this is a physician in the community says, hey, I need a paramedic to go out and evaluate my patient. And so this is another opportunity that Maine EMS is considering of how we can intervene within the opioid epidemic within Maine, is using community paramedicine to extend our healthcare resources and infrastructure that we currently have. So I'm sorry to take so much time on background, but I think it's important to kind of discuss how the system works first. So I will turn it over to Darren to kind of discuss our data and our data systems. Darren?
Yeah, so thank you, Sam. Within Maine, every EMS activation that occurs requires a report to be entered by the EMS clinician. We are currently getting pretty close to 300,000 such reports a year into our system for emergency medical calls as well as interfacility transfers. Those reports are required to be entered within 24 hours and are held in a state repository, and we have a local copy of our state repository here. So it gives us some really good access to our data and allows us to really analyze that data, and in particular context with today's discussion, we have a really good ability to look at non-fatal and fatal overdoses. So our data is nationally defined. So every EMS agency pretty much throughout the country, all 50 states and a couple of territories, track all their data in the same fashion. So that allows us to actually do comparisons to see how we're doing along with our national data. So Sam, if we can go to the next slide.
Absolutely. And I realize I didn't put what the asterisk means here for fatal and non-fatal encounter data. It is important to note that there are some limitations to our data insofar as not all fatal overdoses actually result in an electronic patient care report from EMS. For instance, if the person is already deceased and beyond resuscitative measures, there typically is not a patient care report from EMS. Sometimes EMS is not even dispatched to those patients. Those are patients that it's obvious death. So there's line of lividity, the blood is settling in their body, they have rigor mortis, those types of things. And then some non-fatal overdoses may not be included in our data set as well. For instance, if someone is given naloxone and they are resuscitated and they are awake when we arrive on scene and they say, no, I don't want EMS, I don't want to talk to you, there may not be a run report for that individual because we cannot collect the data from them because they don't want to talk to us. So just putting some caveats of our data has some limitations, but it is probably one of the most robust non-fatal overdose repositories. And thank you, Darren.
Yeah. So we actually have the ability to produce a number of reports, and here's a sample of a dashboard that we produce on a monthly basis around the first of each month. This is a opioid overdose dashboard that has some key values and a look at what happened, in the prior month regarding opioid overdoses. If we can. Some of these might be a little bit hard to see, so I've blown some of these up. So Sam, if you want to click on the screen there one more time. So, EMS opioid overdose encounters by month. This simply looks at the entirety of the prior year and the current year to date. One thing I will mention when we refer to opioid overdose encounters is that they are suspected opioid overdose encounters. We don't do any field testing or anything of that nature that actually verifies and confirms this. So this is just simply based upon the EMS clinician's impression of what this patient's problem is, and can certainly be bolstered by the administration of naloxone and the patient recovering. So another interesting Zoom here is the patient disposition, and Director Hurley had mentioned that we see a lot of patients that don't go to the hospital, and I think that's key to some of the programming that he's going to be discussing. As you see here, this top green line, those are the people that we end up transporting to the hospital, but the blue and red line below it represents people that either decline care or who we treat and then they decline care. And those people are people that EMS unfortunately has to kind of walk away from. So, and we're looking to turn that around. We're not able to take those patients and get them to some additional continuing care for the care that they need. Sam? So, did you want to talk about this one, Sam, or? Oh, you're muted.
Yeah, sure. I'll be more than happy to talk about this. So this shows data from 2018 to 2022 year to date. So please note that you see what appears to falsely be a plateau at 2022. That does not include data from the month of December. So please keep that in mind. It may not be a huge trend up, but please note that that is year to date. So it's excluding a 1/12 of the data essentially. So what you're seeing is the bottom line. So these are responses to EMS. So the bottom blue line shows EMS's response with a cardiac arrest and the EMS crews attempted to resuscitate that patient. Because the scale on the left is so wide, 0 to 4,000, it's kind of hard to see the blue line and the pattern it takes. But what you would be able to see if the scale was a little bit better is you would be able to see this increase and somewhat plateauing after 2020. So from 2019 to 2020, you will see an increase of out-of-hospital cardiac arrest with resuscitative efforts by EMS. The next thing that we will talk about is the respiratory arrest or depression that included administration of naloxone. So these were patients where EMS was dispatched to the call and naloxone was administered by EMS crews. You will see that that has increased in 2021, 2022. There has been an increase there. There's an inflection point. If you look at the green line shows naloxone administration prior to EMS arrival. This is one of the most exciting notes about this graph is that we are seeing a significant increase in naloxone administration prior to arrival compared to 2018. So that means that we are penetrating the community with naloxone. It is becoming more readily available within the community. And so that is very exciting to see, when you have almost a 130% jump in the number of naloxone administrations in the field from 2018 to now 2022. That's incredible work. The last one is the yellow line. That's the overall suspected opioid overdose cases based on our internal case definition that we have defined. There are a variety of case definitions. Many states have their own case definition, but this is based on our case definition. And as you know, Gordon alluded to, we have seen a rise in the number of suspected and known opioid overdoses throughout the state of Maine. So this isn't surprising. It is extremely sad, but is not surprising that this number trends up within the EMS data as well. Okay, Darren.
Yeah, so we do have some really good capabilities to look at our data. I've already mentioned that we have a local copy of our state EMS repository where we can analyze data at a very detailed level. We also use some pretty advanced analytics. This is an application called Biospatial, which allows us to analyze a number of different syndromes and case definitions. This here is overdoses with a layer that's supposed to show the substance use disorder treatment centers. It allows us to really see where our resources are needed and to look at variances over time. So we can actually set this up to look at weeks or months or years and play it so that we can see where those hot spots in that heat map migrate kind of throughout the state to identify seasonal differences and things of that nature. So, just a real quick example of, the level of analytics that we're doing around substance use disorder. So another thing that we're doing is uploading EMS activations for suspected overdoses to ODMAP. ODMAP is a tool that's used for near real-time overdose surveillance. It has its many law enforcement agencies throughout the state of Maine uploaded their data. So one of the things that we took an initiative to do was upload suspected overdoses for all EMS agencies throughout the state. So you'll see that information here, and this is just a screenshot of what it looks like. You have the ability in here to filter things based upon time and county and agency, the nature, whether it's a fatal overdose, whether naloxone was administered, all those things are different filtering parameters. And there are alerting capabilities as well, so that you can actually sign up for alerting so that when there are spikes or surges in certain areas, you can be informed to make sure that you have the appropriate resources to be prepared to respond to those.
So when we're talking about now kind of migrating into from data to programming, our real motivation was to how do we capture that 20 to 30% group that are not being transported to the hospital. In the emergency departments, we've set up programming where they can begin Suboxone treatment, where they can connect them to care, where they can dispense Naloxone, where they can do all of these great things. But what we are seeing is approximately 20 to 30% of the people who are overdosing in the field are not actually going to the emergency room. So how do I bridge that care for them to make sure that they are getting those same opportunities that someone who is transported to the emergency room is able to take advantage of? in the field. And so the first program we want to discuss is the Naloxone Leave Behind program. Maine EMS had to work with the governor's office and others to implement LD 1333, which is an act concerning dispensation of naloxone by EMS. The reason Maine EMS has always had the ability to administer naloxone. The problem is that dispensing naloxone, so giving someone a prescription medication to use at a later date as a licensed healthcare worker was a little bit problematic. The dispensing, because they're a licensed healthcare worker, the dispensing regulations really limited their ability to dispense, quote unquote, dispense medications. And that's really limited to physicians and physicians and pharmacists. They are able to dispense meds. And so we had to change the law allowing EMS clinicians to readily dispense. So at this time, EMS clinicians can dispense naloxone to any patient, family member, or friend on scene of a patient who refuses to be transported to the hospital. The primary reason that that is based around their refusal to be transported to the hospital is because the hospitals have these programs in place as well, and they receive a separate allocation of naloxone supplies through separate funding resources that don't necessarily supply this program. All EMS clinicians are required who are participating in this program are required to do an online training. This is just a screenshot of the online training that they must complete. A lot of this training is not about how to administer naloxone because EMS clinicians know how to do that, and they can easily walk someone through that process. There's a little bit of how to explain that to a patient. But what it really focuses on is stigma. Why is it important that we do this? What principles of public health are important here, and understanding addiction and those concepts, because they know how to tell someone to use intranasal Narcan. And so the Narcan and some leave behind materials, are all provided free of charge to every EMS agency in the state of Maine who is participating in this program. And so we, through collaborative with the University of Maine, are able to dispense out naloxone kits to EMS agencies, as well as the leave behind materials that have resources, the Don't Use Alone app, telephone numbers, options referral programming, and other materials. And we leave that with the naloxone kit for patients being left behind. And we have a little bit of data about what this program has revealed so far. This program was implemented on December 1st, 2021. So we are officially 1 year into this program, and we'll talk about that really quickly. So 1 in 5 suspected opioid overdoses ends in an opportunity to leave naloxone behind. In Maine, this is as of October 31st, I believe, when we pulled this data, 18 attempts for every 100 opportunities to leave naloxone behind were made, and nearly half of those were successful when offered. So it means that they are accepting it when offered, at least approximately 50% of the time. Based on the naloxone kits that we have left behind as of October 31st, I believe there are about 118 kits left behind. We have some preliminary data. As a scientist myself, I think it's very important for me to acknowledge this is preliminary data and we have a very small N. 118 is a very small number compared to the 3,000 overdoses 3,000 plus overdoses we may see in the state of Maine. So please note this is preliminary. We can't make solid conclusions from this yet, but what we are seeing is that per 100 kits that are left behind when a patient suffers an overdose, we have not seen fatal outcomes from those patients in an EMS encounter. That doesn't mean that people did not die. because again, we do not have access to all of the fatal outcomes. So if someone is in rigor mortis, we may not know that they are dead. But what we are seeing is per 100 kits that are going out, we are seeing 0 subsequent fatal overdoses in that population. They may have subsequent overdoses, but they're not fatal. Darren, did you have?
No, you're
Okay, making sure I wasn't messing up. However, when we look at the opposite of that, for those persons that a kit was not left behind, the rate per 100 is 6.6 people per 100 had a subsequent overdose where EMS documented a fatal outcome. That is concerning. Again, this is all very preliminary data. And so we are just now scratching the surface of it 1 year in. However, what our preliminary data is suggesting is that naloxone leave behind, particularly for this group of people, this 20 to 30% that aren't being transported to the hospital, is very, very important. And saving 6.6 lives per 100 to me is very, very important. And so that's what we have found so far to date. One of the things about the implementation of this program is it is very new in Maine, and so it was optional for services or EMS agencies to enroll and participate in this program. As of December 2nd, so as of today, 21% of EMS agencies have ordered the naloxone leave behind kits, and 12% of EMS clinicians have completed the training. It's important to note that we may have 5,505 EMS clinicians, but we don't necessarily have 5,505 EMS clinicians working. So we imagine that there's approximately 2,500 to 3,000 EMS clinicians who are actively practicing in the state of Maine. So our percentage of penetration is actually higher than 12% for active EMS clinicians, but it's hard for us to make those connections. We have to do, there's multiple data sources we have to compile to actually see who are active clinicians based on the number of patient interactions they have versus our learning management system where we list completion of this course. So we believe we have greater penetration into the community with this training percentage-wise, but 699 have completed it to date. The exciting thing about this is that as of December 1st, 2023, which is the next protocol start date for the state of Maine. So the state of Maine has statewide protocols. Every patient in the state of Maine is treated the same, whether you're in Jackman, Maine, Presque Isle, or Portland, everyone is treated by the same EMS protocols. And so our protocol cycle is biannual. So we had one in December 1st, 2021. Our next one will be December 1st, 2023. As of December 1st, 2023, it will be required for EMS clinicians to dispense naloxone for persons who refuse to be transported to the emergency room following an overdose. They will have to offer the naloxone to those persons as part of the protocols. So we are excited about that phase, and we will begin messaging on that in the immediate future at the beginning of the year, so people can go ahead and start completing the training. But that is the direction we are moving to require it. But it is a phase-in process, and like I said in the beginning, there's still a lot of stigma around naloxone and how it works, and EMS is not a unique healthcare entity that doesn't have stigma associated with that. And so it takes explaining and talking to people to make sure they understand exactly what they're doing and why they're doing it when it comes to this type of harm reduction strategy. So, Megan, do you want to talk about this?
Sure. So another really great programming opportunity that we have to utilize is Options. Options is an acronym for the Overdose Prevention Through Intensive Outreach Naloxone Safety Initiative. So this is a program that's coordinated through the Office of Behavioral Health, the State of Maine Department of Health and Human Services, alongside with ourselves, Maine Emergency Medical Services, and a variety of other entities through DHHS, Health and Human Services, to work towards a strategic united front for harm reduction to excuse me, to reduce the amount of fatal and non-fatal overdoses for opiate use. So within the options program for the state is the placement of options liaisons. So these liaisons are placed throughout all of the 16 counties in Maine. For most counties, there's 1 to 2 liaisons at this point. So of course, thinking about servicing a large catchment area for a county, like our more rural counties with larger surface areas and less urban areas, 1 to 2 liaisons is a little bit of a small order at this point, but the goal is to continue developing and increasing those numbers to improve our response rates and opportunities. So the options liaisons are all licensed behavioral health professionals. So they're working in tandem with our first responders, most often law enforcement and our EMTs, paramedics, other responders to scenes of events. They provide crisis de-escalation in the moment. They help provide a different perspective for responders, help de-escalate situations basically to help move towards a more positive outcome in that experience or scenario for the patient and responders all alike, which also helps contribute further to our work against stigma and shame or guilt associated with these encounters for people. So when we want to make a referral for the options program, how people access it, this happens when those 20 to 30% of the time that people decline or refuse a transport when encountering EMS in the community. So this is a not a too terribly intensive process for people, fortunately, which hopefully improves people's willingness to accept the help. But when there's a suspected overdose, people refuse the transport to the hospital for further treatment. They have the option to sign a consent right there with EMS or paramedic personnel that goes right into our central access point for documentation. They get contact information for the person, so the options referral liaisons receive that information depending on the county that the response is in, so they can work on their outreach efforts for that person. Basically giving that person a repeated opportunity to seek that transport, seek additional help or resources for recovery options or other services to help overcome their barriers or needs to work towards a level of well-being or health. Overcoming addiction isn't a first or even 6th or 8th or 11th step for some people. It takes as much time as it takes for some people. And the options program provides those extra chances. And of course, the Naloxone program within this helps give those people those additional chances when we're able to reverse the effects of an overdose. People get that second or third, whatever chance they need to get the help that they would like. Is there anything else you can think of, Sam, for that?
No, so we have been working with the options program to build out a couple of items that are related to this. And I know when I looked at the attendance, there were some folks from options programming. And this is really important of how do we connect people to care? And I saw there was a question in the Q&A about something similar. How do we connect people with care? To care. And so this is really our opportunity to connect people with care, having a streamlined pathway in our community. And so what we have had to do is build education around what is options. So if I'm getting informed consent from someone to share their PHI or their PII, their identifying information, their telephone number, their name, their contact information, and there's some PHI associated with that because the receiving party is going to know that they had an overdose. I need their explicit permission to say, yes, you can send my information, but I need to make sure EMS clinicians are prepared to educate people on what the patient is saying yes to. Because what I don't want it to be is, I don't want it to be where, oh, I can send your name to someone. Do you want to do this? Because if we don't educate people, that's likely what will happen, and it'll be a missed opportunity. And options has so many resources, not only treatment, but housing and other resources, food security. There's a plethora of opportunities that are available through the options program. So we really want to build out that pathway. The education will be completed by the end of this year. We actually have a meeting with the contractor next week to finalize that education, and then we will be deploying it, and the system is already built within our run reporting system to capture the informed consent signatures so that we can release it, and the secure pathway and data transfer mechanisms have already been built. So this will be coming soon, in the very first quarter of the year. So the next thing is something you may have heard about in the news. It's funny. It got picked up by the news because I had posted some of the positions that we are hiring for in our office that we will be working on this project. So, especially in rural communities in Maine, there just are not enough resources to connect people to care for treatment. So what Maine EMS is working to do is we are working on building out a pathway for the initiation of Suboxone in the field by EMS clinicians following an opioid overdose, should the patient not wish to be transported to the hospital. This is validated and evidence-based. This has been done in Contra Costa, County, California, as well as Camden, New Jersey, as well as many other locations, smaller locations throughout the nation that have adopted this type of programming. So this isn't necessarily a novel concept. The novelty to this concept is implementing it in more of a statewide fashion and implementing it in such a way that it engages rural communities, because the original programming pathway has really been for these urban suburban communities that have more access to just-in-time treatment referrals for continuation of care. So what we are looking to do again is to enable that access to care. So an EMS clinician responds to a call, they reverse an opioid overdose. The patient says, no, I don't want to go to the hospital. The EMS clinician attempts to convince them to go to the hospital. We want them to go to the hospital because there are more resources there. And should they still continue to not wish to go to the hospital, we will have the ability to contact online medical control, which will be a physician medical director that they will be able to reach out to. That physician medical director will be given the patient's information as well as their clinical condition, their vital signs. They'll be able to obtain a CAL score for those who are familiar with CAL scoring, and they will be able to authorize the EMS clinician to administer Suboxone to this patient. Additionally, that physician, as well as 2 members of our staff that are hired through some federal grant dollars, will be assisting in coordinating care following the initiation of that patient on Suboxone. And so we have to make sure that what we're doing is not giving someone a dose of Suboxone and saying, good luck, wish you the best, see you next time. That doesn't work. So how do we follow up and connect that person to care? Our preliminary strategy that we have we are beginning to formulate is, our first option will be to refer them to some of the online and telehealth based treatment programming, much like the Department of Corrections has following discharge. to refer them to that type of programming. In communities where there are resources available, like the Portlands of the world, the Lewiston, Auburn, and even I think Machias has a treatment facility. In those places, we hope to establish community partnerships so that we can refer that person to go there, within the next 24 to 48 hours. However, if we are unable to make that connection, and say, for instance, someone does not have a smartphone or an internet capable phone where they can do the virtual programming, and there isn't something local, how do we take care of those folks? Remember that little conversation about community paramedicine? The one thing that was on the far right with a dotted line saying this is not emergency. That's where we see potentially utilizing our community paramedicine clinicians to assist in bridging the gap. So not functioning as a long-term treatment provider for MOUD. That is not Maine EMS's role. We do not want to get in the business of long-term treatment or care. However, how do we bridge the gap until we can get them to that treatment or care? And that's really what we are looking for. So when all else fails, and all of the other mechanisms that we have in place do not work to connect people to care, the idea is to potentially utilize our community paramedicine infrastructure to help bridge the gap and partner people with care, where the community paramedicine clinician could be dispatched or sent to the location of this individual, whether they are experiencing homelessness and they have a nondescript location, or they're living in a home. They could go to this individual and administer their next dose. It kind of goes back to the 1333 legislation. We cannot dispense. So I cannot give them multiple days worth of dosing. We will have to go in and administer the doses. But this is our last resort of connecting persons to care. The idea is that we would do that no longer than a week or two at the very most, but it gives us a bridge until we can connect people to care within communities. So this is something we are working on. We are hoping by the end of 2023, we will be initiating pilots throughout the state of Maine. We have the regulatory framework in place to do this. We will be working with our Medical Direction and Practices Board to develop the protocols around this. Fortunately for us, the National Association of State EMS Officials is also working on this simultaneously with a stakeholder group of state EMS leaders from across the nation, because there are many states that are interested in doing the exact same thing that we are talking about. And so we will be working collaboratively with them to share best practices and make sure that we are kind of on par with what other states are doing as we all move in this direction. But this is very exciting for our rural communities as well as our urban communities. But we are very excited for those communities that may not have or may have limited access to Suboxone and MOUD. So here are our names and contact information should you need it. I know there are many questions in the chat and in the Q&A, and so I will turn it over to I will turn it back over to Gordon to help facilitate.
Yeah, I'll just help with the questions and answers, Sam. And thank you, Megan, Sam, and Darren for an excellent presentation that has provoked a lot of questions. I don't think we've ever had this many questions, but I think we can get through most of them. I answered a couple online, and I'm just going to toss them to you, Sam, and then you can give them to the team if you need to. First one, you and I have talked about, but I'd rather have you answer it. Is there a discussion about expanding community paramedicine to serve unsheltered individuals who may also need foot care or other medical assistance in addition to connections to recovery supports and harm reduction office connections? That's the question. So I think you'll want to at least define community paramedicine for those on Zoom that aren't aware of it.
Yeah, absolutely. And it just says anonymous attendee. So thank you, whomever presented that question. Yes. So the short answer is yes. So community paramedicine, again, is non-emergency. They do require a medical order to be sent out. So there will have to be likely a medical home for this patient. Someone has to send us. We cannot self-dispatch to a location. However, community paramedics and the community paramedicine scope of practice includes wound care and wound management, as well as foot checks, diabetes care, and a variety of other services. The thing we have to be very cautious of is that we're not duplicating home health services. So this is intended to be like intermittent and is intended to be like, we're going to send you once or twice, but not we're going to send you once a week for the next 10 weeks to check on someone, because what we don't want to do is step on the toes of our home health partners and the statutory language that they have. But yes, we do have capacity to do that, and the community paramedicine program currently, as exists, does have capacity to support that as long as there is an order to do so.
Thank you, Sam. The next question is from one of our regular viewers, Kathleen Olschlegel. And Kathleen, I probably butchered that last name. I apologize. The question is, and this is really unique to EMS, so I did not have a clue what the answer is. To track OD and ODD with patient refusal, can you document using a John/Jane Doe on run sheets to show details of transport refusal while still having up-to-date data?
So, Kathleen, that's a great question. So the one thing is if a patient refuses transport to the hospital, we have that data. We have that data set. What we don't have is we get there, the patient is awake, alert, and says, I don't want to talk to you. And that it would be hard for us to document what the patient complaint is because they don't want to talk to us. We may assume that they are an opioid overdose because we have heard from the 911 dispatch that they were administered naloxone. However, the problem is it colors our data as far as that we're making a lot of assumptions there. But we do have the data for all patients who refuse transport and are evaluated by EMS. We have that data, and we have those numbers. It's those patients who say, I don't want to communicate with EMS at all. And we can say that same patient, even if we evaluate them, but they don't want to give us their name, there's a way for us to document that patient without putting a name. But if we do not make patient contact, as far as we do not have any kind of interaction with them or clinically, we don't have a way of documenting that.
I really like this question. I didn't dare answer it. I think everybody should hear the same answer. And this is from, again, our anonymous attendee. Is EMS able to also distribute fentanyl test strips?
Yeah, that is a great question. And that is something that we have been looking into. The question for us is really looking at the science behind it, and we're distributing medical equipment. And so it brings about the 1333 argument again. Can we distribute medical equipment to leave behind with people? There are just some questions about whether or not we can do that. I have engaged the Medical Direction and Practices Board about this conversation. One of the concerns that that was brought up just anecdotally off the cuff was the test strips aren't intended, that we saw were not intended for this type of use. They were intended for different uses. And so having a physician order a test strip for off-label use and then having an EMS clinician subsequently do off-label use instructions and those types of things makes it a little bit more complicated, but not necessarily impossible. So it is something we are looking into, but we cannot at this time.
And let me clarify too that since the the possession of drug paraphernalia was decriminalized, and anyone can, in fact, distribute fentanyl test strip. What I didn't want to address was there are strict protocols for EMTs and EMS staff. So even though anybody on the street can distribute it, EMS may want to do it in a much more controlled environment, and I understand that. Next was a good question from Shannon McIntyre. I work for a treatment center for substance use disorder here in Portland. Please let me know what we can do to be more helpful. I work closely with Options Contacts, but if there's more I can do to help, please let me know. And there was a similar question about, how can a treatment resource make sure that they have the opportunity to be known to local EMS personnel. I think we can answer that question quickly by just saying, bring yourself to the attention of your local EMS provider and offer your assistance. There was another important one here. Yeah, go ahead, Sam.
Also for that, we are bringing on two substance use disorder response coordinators. We would love to work with you at the state level to kind of help identify. What we don't want to do is put a large burden on our local agencies to have to bridge all of these gaps from scratch. So feel free to reach out to Megan or myself and share your interest, and we will be more than happy to work with you. We are excited about making those connections.
This is a similar question from Mickey Rice. Does EMS also give referrals to local harm reduction programs? So that if the individual isn't really interested in recovery, but wants to do safer use and be connected with harm reduction and be connected to a syringe program, for instance, can EMS make that referral?
So we do have the referral to the options program. That way it streamlines our referral process. So that way we're not having to keep up with, oh, this center closed this week, or, this is not the way to get into that program anymore. And so our pathway is really referring to options and letting them be in the coordinating body. However, with the Naloxone leave behind, we do have handouts that include QR codes and hyperlinks for people to pursue resources online that are available, that have listings of these resources that are available. But what we're trying to do is streamline it as much as possible for the EMS clinicians.
Yeah, I'm just scanning the questions now. I think we can probably handle this one. It follows up on your comment about the protocols moving to the point where EMTs can give Suboxone under medical direction. How does that, the question from Mickey is, how does that work when you give Suboxone to people? Suboxone can put people who have physical dependency into precipitated withdrawal, but in some cases up to 96 hours after last use. How do you handle that?
Yeah, that's a great question. And the research that we've seen, particularly coming out of Camden, New Jersey, and some of the other places where this is in place, is that the beauty of it is we do it immediately after reversal with Naloxone. So they're already in withdrawals when we initiate someone on Suboxone because we have already reversed them with the Naloxone, and it's not initiating someone on Suboxone when they're not in active withdrawals. So that in Camden, they have not seen any cases of precipitated withdrawals in their programming. And so that is one of the benefits, is that they're already in withdrawals when we are initiating them.
We'll do one more. Is it possible to expand community paramedic programs to urban areas as well, in order to provide service to unsheltered individuals in encampments, for instance, perhaps in conjunction with an options liaison? And our options coordinator, Rob Porter, asked really the same question: can an options liaison request community paramedicine to accompany them on an outreach to a homeless encampment. I don't know whether we're there yet, but I'm going to let Sam answer the question.
Yeah, so community paramedic programs in the state of Maine can exist anywhere. So I know South Portland is in the process of potentially creating a community paramedicine program right now. One of the largest community paramedic programs in the state is based out of Lewiston, Auburn area with United Ambulance. So it is not limited to rural or urban. It can be anywhere. And there can be partnerships with other response organizations. What that starts becoming is more of mobile integrated health, where you have different healthcare professionals partnering with EMS. However, our community paramedicine programs do allow for that. To answer Rob's program question, theoretically, yes. However, the caveat is that there has to be a medical order for us to initiate treatment. Based on the way the statute was originally written, is it says it has to be ordered by a physician. So it's not impossible, but there is a little a little jump we have to jump over of making sure that we have a medical order to do so.
Okay, we're out of time. I'm just delighted with the number of questions that some questions have provoked other questions. And the team will get together, we'll answer all those questions, post the answers to our website at AdCare, and let you know that they're done. So I just want to thank our panel. I don't want to keep people over time. Thank you so much, Sam, Darren, Megan. Been a great program. We'll want to do it again in a few months to keep up to date with all these exciting initiatives. So I wish everyone a happy holiday. We'll see you on January 6th. And thanks for your support of our activities.